Dear colleagues, ladies and gentlemen, dear friends, it's a pleasure to be today together with that ISG webinar. Today, the topic is fantastic, it's menopause hormone therapy, but mostly how to minimize the risk and maximize the benefits. We will have two fantastic speakers, Professor John Stevenson, who will start, and Professor Alfred Mueck, who will follow. The presentation are on the impact of hormone replacement therapy on cardiovascular risks, how to get the most benefit from therapy, and the second one on does transdermal estradiol provide less breast cancer risk compared to oral administration. You can see two topics of urging and strong possibilities to improve our daily practice with our patients. The first presentation will be done by John Stevenson. Professor John Stevenson is Emeritus Reader in Metabolic Medicine in the National Heart and Lung Institute at the Imperial College in London, and visiting professor at the Belgrade School of Medicine and consultant physician at the Royal Brompton Hospital in London. As he is one of the members of the board of the International Society of Gynecological Endocrinology. Please, John, you have opened your microphone and share your slides, and then you can have your presentation. The general discussion will be at the end of both presentations.
So there's my conflicts of interest.
Yes.
So what I'm going to do is to talk about how to maximize the benefits of HRT for cardiovascular disease. And I'm going to talk about the mechanisms of action of HRT on the cardiovascular system. I'll then show studies of HRT and coronary heart disease in healthy women, just to show the evidence that it's beneficial. I'll mention the timing of the intervention with HRT, and then the studies of HRT and coronary disease in women with established disease, then routes of administration, and finish with the conclusions. So to start with mechanisms of action of HRT on the cardiovascular system. So I think it's important to know about the mechanisms, because that way we can see how we're going to maximize the benefits by getting the best benefits, both in terms of the metabolic effects and in terms of the vascular effects. So hormone replacement therapy will actually reduce total cholesterol because it reduces the LDL cholesterol, the harmful type of cholesterol. And so these are beneficial effects of all HRT, which will do that. We may get an increase in HDL, high density lipoprotein cholesterol, which is probably a beneficial thing. But if you're giving the hormones orally, that will often also increase the triglycerides, which is not something we always want to do. When you add a progestogen to the estrogen, then depending on the type of progestogen, you actually may stop the increase in HDL, and you might even get a decrease in it. But at the same time, you would stop the increase in triglycerides. So it's really a case of working out which is going to be the greater benefit. But there are other actions of HRT on lipids and lipoproteins. One of the important ones is that it decreases lipoprotein little a, which other lipid modulating therapies, for example, statins, aren't able to do this. So this is an important benefit of HRT. It increases the clearance of the more atherogenic particles from the circulation, so increased small dense LDL clearance and increased clearance of the postprandial lipid remnants. And it also decreases LDL oxidation. So all of these actions are going to be beneficial. HRT also has important effects on insulin resistance, and insulin resistance is a key metabolic disturbance for the development of atheroma and the cardiovascular disease. Oral estradiol improves insulin resistance, and we've several studies showing that quite clearly. So estradiol itself, oral estradiol 17 beta, does show a clear improvement. You may see a slight improvement with conjugated equine estrogens at low doses, but basically they have very little effect at low doses, but may have some actual adverse effects on insulin resistance at high doses of conjugated equine estrogens. Transdermal estradiol 17 beta has just a small effect on improving insulin resistance. It's less than you see with the oral therapies. So these are the effects of estrogen on insulin resistance. But when we add progestogens, again, you may modify this effect. So androgenic progestogens such as norgestrone, norethisterone acetate, medroxyprogesterone acetate will worsen insulin resistance, whereas the addition of a non-androgenic progestogen such as micronized oral progesterone or the very similar dydrogesterone really have little or no effect on insulin resistance. They have no negative effect. And if you give the progestogens transdermally, and of course these are always androgenic progestogens, giving them transdermally seems to have only very little adverse effect on insulin resistance. Now, the other thing to look at is arterial function, because estrogen has very important effects on arterial function. So that estrogens will restore nitric oxide dependent endothelial function, and they increase the endothelial production of nitric oxide synthase. So these are, nitric oxide, of course, is a major vasodilator, but estrogen also reduces the endothelial release of endothelin-1. Endothelin-1 is a very potent vasoconstrictor. So by reducing its release, again, that's going to be a vasodilatory mechanism. Estrogen inhibits calcium channels and it enhances potassium-dependent channels. So both of these actions are also going to be vasodilatory. It reduces the activity of angiotensin converting enzyme, which probably is sort of an anti-arrhythmogenic action. Estrogen reduces smooth muscle cell proliferation, arterial smooth muscle cell proliferation, which is going to be important in preventing the development of atheroma. And it also probably improves vascular remodeling processes. But this is a very dose-dependent action. So all of these actions on the arterial function are going to be largely very beneficial. So those are the main mechanisms of action that we want to look at, and we want to maximize these beneficial effects. So now I want to look at studies of HRT and coronary heart disease risk in apparently healthy women. And in doing so, I will also look at the importance of the timing of the intervention with HRT. So this is an old meta-analysis from Mayor Stamfer and Fran Grodstein, just showing that if you look at various population studies, different types of epidemiological studies, they basically are all showing an association of HRT use postmenopausally and a reduction in cardiovascular disease. And the meta-analysis figure here, shown in the little blue figure here, is showing that this association would suggest about a 40 to 50% reduction in cardiovascular disease with postmenopausal HRT use. And this is mainly from these studies going to be reduction in coronary heart disease. Now, the Women's Health Initiative, of course, was the largest randomized clinical trial to look at effects of estrogen or HRT on coronary heart disease, as well as other outcomes. And following their preliminary publication in 2002 of the preliminary data, where there's a suggestion that it might be causing an increase in cardiovascular harm. When we got the the so-called full results in 2003, there was no significant effect of cardiovascular harm with estrogen plus progestogen. It was not statistically significant. And with estrogen alone therapy, there was a non-significant actual reduction in coronary heart disease events. And subsequent publications from WHI have continued to show this, that there's clearly a difference between the effects of estrogen plus progestogen, this is conjugated equine estrogens plus medroxyprogesterone acetate, compared with conjugated equine estrogens alone. So it's important to note that here we're seeing an impact of adding the progestogen in this study. Now, I want to just mention the timing of the intervention, because this can be quite important. And this is a series of animal experiments from the late Tom Clarkson's group, where they take cynomolgus macaques and they make them surgically menopausal. So in the first experiment, these monkeys are given a healthy diet, they're made surgically menopausal, they're put onto an atherogenic diet to try and induce atheroma development, and then they're randomized to conjugated equine estrogens or no treatment. And what you see at the end of this study was that those monkeys given conjugated equine estrogens are showing a 70% reduction in plaque area in the coronaries compared with the monkeys that were not given estrogens. Now, in the second experiment, the monkeys were given an atherogenic diet right from the start before they were made menopausal. They then were made surgically menopausal, continued on the atherogenic diet, and randomized again to conjugated equine estrogens or no treatment. And at the end of this study, those given estrogen showed a 50% reduction in plaque area compared to those not given estrogens. So still a beneficial effect, but not quite as great as in the first study. And then the last experiment, they were given a healthy diet, made surgically menopausal, put onto the atherogenic diet, but now there was a delay before they started the HRT or the placebo. And the delay was approximately the equivalent of 6 years in humans. And then they're randomized to conjugated equine estrogens or no treatment. And at the end of this experiment, they saw no difference in terms of plaque area between those that had estrogens and those that didn't. And this really gave rise to this idea of the timing concept. In other words, that the sooner you get in with HRT after the menopause, the more benefit you're going to see. And this is probably borne out a bit by the Women's Health Initiative, because if we look at the estrogen alone arm of the study, for those initiating the estrogen below the age of 60, you're getting a non-significant reduction in a myocardial infarction or death, in coronary interventions, and in a composite of these two. So this is now a significant reduction. Whereas in those women who are randomized in the trial to the estrogens or placebo above the age of 70, you're not seeing any reduction at all. You're not seeing any increase, but you're not seeing any reduction. And with the long-term follow-up of the WHI study, in the estrogen alone treatment, what we found was, with the cumulative follow-up, that those initiating the estrogen below the age of 60, compared with those that had gone on to placebo, showed a significant reduction in coronary heart disease events. So with the follow-up study, we're seeing a significant reduction in events below the age of 60. Initiating above the age of 60, they didn't show a reduction in coronary events. But again, they didn't show any increase. They just did not show the reduction. This is a primary prevention study from Louise Scherberg and her colleagues in Denmark, 1,000 postmenopausal women, very early in the menopause, on average only 7 months post-menopause, randomized to estradiol, plus or minus cyclical norethistone acetate. And this trial was stopped after 10 years, but there's an observational follow-up for a further 6 years. And the main outcome they looked at was a composite of coronary heart disease, death, or myocardial infarction, or admission to hospital with heart failure. So this is a composite outcome which was significantly reduced in those randomized to HRT. Interestingly, they showed no increased risk of stroke, venous thromboembolism, or any form of cancer, including breast cancer, in the women who were treated with HRT. And don't forget, they were treated for 10 years. So I think that's an important safety finding as well from this study. Study from Howard Hodis and colleagues in California, the ELITE study, where again they were looking at the timing hypothesis. So they recruited 640 postmenopausal women who were studied for up to 6 years, and a group of these were within 6 years of the onset of the menopause, and the other group were beyond 10 years of onset of the menopause before they were randomized to either oral estradiol or placebo. And for the non-hysterectomized women, they got vaginal progesterone gel. And the outcomes, the main outcomes they looked at were intermediate thickness of carotid arteries demonstrated by ultrasound. And what they found was that the progression of intermediate thickness increases was significantly reduced in those women who were starting their HRT within 6 years of the menopause, whereas those who commenced the therapy in the trial who were beyond 10 years postmenopause, you didn't see this significant reduction. So again, this is showing the timing effect. I'll just show you these data because these are data that we presented recently at the International Menopause Society Congress in Melbourne. And this is a study looking at major adverse cardiovascular events, comparing oral estradiol 17 beta with micronized oral progesterone versus conjugated equine estrogens with medroxyprogesterone acetate. And it's a retrospective observational study from a medical insurance claims database, the Symphony database. So what they did from this huge database, they selected women who were aged above 40 years who were receiving their first prescription for either the estradiol progesterone combination or for conjugated equine estrogen MPA combination. And the data were collected over a follow-up period of 2 years until the end of clinical activity or the cutoff at 2 years. And the endpoints they were looking at were hospitalization for myocardial infarction, stroke, or heart failure. And you can see on the graph here, the red line is showing the weighted analysis for conjugated equine estrogens plus MPA. And you can see that there is the percentage of women that are experiencing an event is increasing gradually during the study, whereas the women who were taking estradiol micronized oral progesterone showed a clearly less increase in these events. So there's an obvious difference between these two forms of therapy in terms of these major adverse cardiovascular endpoints. We actually just looked at the data, although obviously you cannot do a direct comparison, but looking at the data from the WHI trial. So we selected all the women in the WHI trial, of course, were between 50 and 79. So from the Symphony database, we selected women also aged between 50 and 79 and looked at the unadjusted event rates. So for non-fatal myocardial infarction, it's 4 for the estradiol progesterone, 21 for conjugated equine estrogens, MPA. And if we compared that to the figures from the WHI trial, so 21 in the Symphony study, 30 in the WHI trial, so they're fairly similar. And if you look at the placebo effect, that was obviously a better effect than with the conjugated equine estrogens. So compared that the placebo, just 23 events, compared with the estradiol progesterone, only 4 events. And the same sort of finding we've got for stroke as well. 9 events for estrogen progesterone, 34 for conjugated equine estrogens, and 21 in the WHI trial for placebo. So it's suggestive. Clearly, it's not a direct comparison. We can't do that, but it's suggestive of a more beneficial effect of this combination. And the meta-analyses we've got from randomized clinical trials, again, show quite clearly that for women initiating HRT below the age of 60, there is a significant reduction in myocardial infarction or death, and that is not seen in women initiating the HRT in these studies above the age of 60 compared with placebo. Again, there's no increase in the older women, there's no increase in events, but you're just not seeing the same reduction. And lastly, from Finland, the study looking at coronary heart disease death, and again, dividing women initiating HRT below or above the age of 60, those initiating below the age of 60, a clearly significant reduction in coronary heart disease death, non-significant reduction in those initiating at a later age. So I think that really proves the point that HRT can be beneficial for coronary heart disease. So now I'm going to just quickly go through the effects of HRT in women who've got established coronary heart disease. This was a study that Pete Collins did at the Royal Brompton Hospital, where he's infusing estradiol into diseased coronary arteries in women undergoing angiography. And what he does is to infuse acetylcholine, which in a diseased artery will cause a constriction, but in a normal artery would cause vasodilatation. And in these women, these diseased coronary arteries, then you're seeing the constriction here from acetylcholine. He then infused estradiol for 20 minutes into the coronary arteries and repeated the challenge test. And now you can see he's reversed it, that they're actually getting the vasodilatation with the acetylcholine, which is what you would expect from a healthy artery. So it's just demonstrating that estradiol can be beneficial even to diseased coronary arteries. And another study they did at the Brompton with Giuseppe Rosano, this time looking at women with who've got established coronary disease and looking at ECG exercise tests and seeing how long it takes to show ECG exercise of myocardial ischemia, a placebo versus estradiol in a randomized trial. And you can see that those women randomized to estradiol, actually, it takes longer for the myocardial ischemia to come on. And because of that, they're able to exercise for a longer time as well. And they followed this up, Giuseppe followed this up with a double-blind randomized crossover study, 26 postmenopausal women with microvascular angina, randomized to either 100 micrograms estradiol patch or placebo, and looking at the number of episodes during the study, number of anginal episodes, you can see that there's a significant reduction in these with the estradiol 17 beta. Another study looking at effects of HRT on angina, another double-blind randomized placebo-controlled study over 6 weeks, looking at myocardial perfusion reserve as measured by PET scanning. And this is the HRT that they were given or placebo. And what you can see that there's no difference in the perfusion reserve with the placebo, but with estrogen, with the HRT, there's a clear improvement in myocardial perfusion reserve shown by this study. So again, more evidence that it's doing some beneficial effects. And lastly, looking at the effects of HRT on survival following a myocardial infarction, a big population study from the US. And what this shows is that those women who were on HRT at the time they had a heart attack had a significantly better survival than those women who were not taking HRT. And lastly, just to mention routes of administration, this is looking at the effects of HRT, oral HRT, on venous thromboembolism. And so this is a big study from the UK database, GP database. And the first column here shows the effects of oral HRT increasing VTE risk, but transdermal HRT is shown by the green columns. You do not see any increase at all. If we then look at the effects of estrogen alone, oral estrogen alone, shown by this column, there's an increase. And if you add any progestogen to this, there's a further increase. And probably the biggest increase in VTE is conjugated equine estrogens plus medroxyprogesterone acetate. The only group of oral therapy that this didn't show was a combination of oral estradiol, dydrogesterone, where there was no significant increase in VTE. So again, just showing now the importance of route of administration, but also probably the importance of the progestogen. And the very last study to show is again something we presented at the IMS in Melbourne. 45 postmenopausal women randomized to either an ultra low dose oral treatment, 0.5 milligrams estradiol 17 beta, together with 2.5 milligrams dydrogesterone, and comparing this to an equivalent dose of transdermal estradiol, giving 25 micrograms of estradiol and 85 micrograms of norethistone acetate. And the main outcome we were looking at here were parameters of thrombin generation. And without going through big detail of this, what we found, there was no significant difference between these two treatment groups in any of the thrombin generation parameters, suggesting that by using a very low dose of oral, it was probably about the same as giving transdermal in terms of the likelihood of VTE risk. So just to conclude, what I hope I've shown you, firstly, that the totality of current data indicates that HRT is beneficial for prevention of coronary disease, coronary events. And I think that that conclusion is still absolutely valid, even in the light of the latest findings published by the NICE guidelines update, where they're not indicating this. But I think that that is an incorrect conclusion from the NICE guidelines. The benefits I've shown you can certainly depend on the type of hormones, possibly the type of estrogen, with estradiol being more beneficial, particularly the type of progestogen, with the non-androgenic progestogens being much more beneficial. The dose of hormones can be important, as can be the route of administration. And the age of initiation of therapy. The closer to the menopause you are, the more benefits you're going to get. So I think that's hopefully summarized what we can say in terms of maximizing the benefit of HRT for cardiovascular disease, specifically coronary heart disease. Thank you.
Thank you. Thank you. Thank you, John. Beautiful presentation, fantastic list of data who all show and go in the same line, that as early as possible, the treatment with estrogen is protecting the cardiovascular system. We will have a huge series of questions and discussion already coming. Now it's my pleasure to invite Professor Alfred Mueck for his presentation on does transdermal estradiol provide less breast cancer risk compared to oral administration. Professor Alfred Mueck is professor of endocrinology and clinical pharmacology, working at the University of Tübingen in Germany, and as honorary director at the Beijing Obstetrics and Gynecology Hospital in China. Lifelong president of the German Menopause Society, co-founded China's first menopause clinic and International Fertility Protection Center, and leads the Chinese-German Society of Obstetrics and Gynecology. And also, Professor Alfred Mueck is also member of the board of the International Society of Gynecological Endocrinology, and I'm happy to have him. Alfred, you have the microphone. Please share your screen, and we will start with your presentation. We are all expecting.
My title is Does Transdermal Estradiol Provide Less Breast Cancer Risk Compared to Oral Administration? I want to say that it is much more difficult than this excellent talk by John Stevenson, because we have, you hear me?
Yes, 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 perfect.
It's much more difficult because we have no real studies comparing oral and transdermal. We can only indirectly make some conclusions. And this is also a problem because there is not so much data about breast cancer risk with the transdermal estradiol. So I would first say that this statement, which has been made together with Shapiro, is very important. Together with John Stevenson and Shapiro, we have been in a group where we assessed all the studies with breast cancer risk and HRT. And Shapiro is really all know it was, he died a few years ago, a very important epidemiologist. And his statement was that epidemiological and clinical studies never will predict the breast cancer risk of an individual woman. Only screening for risk factors and for known mechanisms will identify the women at risk during HRT or will provide the best choice of HRT. I would say that it is really a very good statement what we had done in this publication with Shapiro, because we have not the possibility to test our hypothesis with many studies. I have a certain conflict of interest sponsored by various companies. I'm honorary president for life of the German Menopause Society, but I will, so I have a really a good attitude to HRT, but I will try to make my presentation without any preconditions. Now, the fear of breast cancer also for us, our patients in China, is extremely, we always need many minutes to explain daughter and mother about HRT and that we can reduce the risk. So you know this when you are working in the clinical field. And in the laboratory field, we have since 2010 in Germany, Chinese doctors educating in breast cancer research. We have published about 50 studies on experimental research about breast cancer risk and hormones. So it is always a problem because we have to extrapolate from the experimental field to the clinical field. In the clinical field, I have the possibility in China now for 10 years. I'm also teaching and in China because we have in the clinical field so many patients, so we can try different medications and look what could be the best solution. Also, if we have the problem that some strategies are not very often used or not very often compared. In the Capital Medical University, we have about 40% of patients from Beijing, and in our gynecological endocrinology, we every day see about 500 outpatients in the Department of Gynecological Endocrinology. We see this problem of breast cancer risk on HRT always when we have to explain to the patients that we want to use HRT. Now, we have two main pathways for hormone carcinogenesis according WHO. This is the proliferation mechanisms, and this is the development of potential genotoxic metabolites. Now, the first proliferation mechanisms is very well known, but the second is not so well known, although it is discussed since many years that certain estrogen metabolites can be carcinogenic, and the conditions when they could be carcinogenic we have investigated in many experimental studies. Now, for proliferation mechanisms, we have to see that there are also the growth factors, the stroma from stroma that are working about EGF, IGF, together with other factors like estradiol, and the growth factor, the proliferation mechanisms are well investigated. Not so well known are the mechanisms via the estradiol metabolites. I will come in 5 minutes on this. Now, regarding the proliferation mechanisms, we have the stromal growth factors which proliferate, and we have certain membrane-bound receptors which can, in combination with certain progestogen, induce the proliferation by the membrane, and we have the Rankel system, which is intracellular, which these are the two main systems which are important in contact with this mechanism of proliferation. Now, to make it simple, starting with the first cancer cell, it needs at least 10 years when we see a cancer diameter of 1 centimeter. So it is a long time under normal conditions until we see the clinical cancer. And when we stop treatment after, say, 5, 6, 8 years, we will not see the clinical cancer. However, when we add progestogens, we have with a synthetic progestogens a very strong proliferation effect, and we can see the clinical cancer, which means 1 centimeter already after 5 to 6 years. So adding synthetic progestogens very strongly increase the proliferation effect. With estrogen only, the proliferation is not so strong, so we need mostly 10 years, 15 years to see with estrogen only any breast cancer risk. Indeed, in the WHI study and 5 other studies, we see with estrogen alone also protective effect, and this is often in the gynecological endocrinology that we have a dual effect. So estrogen can proliferate, but can also decrease breast cancer risk and can induce apoptosis, especially if there was a withdrawal of when you withdraw the estrogen for 3-5 years and start again, then you have apoptosis mechanisms. So we have this studies that we have via growth factors the increased proliferation, which is there is no difference between oral and transdermal estradiol. The progestin addition is important that we have two main pathways, the genomic pathway, which even can decrease the breast cancer risk. So this pathway is not important to see differences between oral or transdermal HRT, but the membrane-bound pathway could have differences, and this is what we are investigating in our research. So the membrane-bound receptors may have different effects with respect to the use of different HRT uses. And in this membrane effect is a so-called PGRMC1 important, what we have published in about a dozen papers. This is in the center of the mechanisms of membrane-bound mechanisms. And we see a very good correlation of the blood concentration or of tissue concentration of this receptor, PGRMC1, with tumor characteristics. And there we see, but in this respect, we see no difference between oral and transdermal HRT. So with a mechanism with proliferation effects, we see with HRT no difference between transdermal and oral estradiol. Now, the second mechanism is the development of potential genotoxic estrogen metabolites. It is coming with DNA structure changes, DNA damages, followed by mutations. And in this mechanism, there also, we know for a long time, could be differences between oral and transdermal estradiol application because we have a different amount of estrogen metabolites given estrogen orally or transdermally. This this pathway is via so-called catechol estrogen pathway. I will comment this in a minute. Was also very well investigated by Richard Santon, and we know from also from his research that there could be differences between oral and transdermal HRT. And we say that there is a problem with those so-called carcinogenic metabolites because we need additional factor to get a so-called carcinogenic metabolites, which we have published recently. I will come in this in a minute. Now I have to go a little bit to chemistry, biochemistry. On the right side, you know this from estradiol, we have the metabolism to E3, to estriol, but we have a so-called A ring metabolism, the steroid A, B, C, D ring, and in the A ring metabolism, we have so-called catechol estrogens, 2-hydroxy and 4-hydroxy estrogens, which are the precursors of so-called quinones, which can be potential carcinogenic, or the estradiol, the catechol estrogens here in the mid can also be methylated, and this methoxyestrogen are not carcinogenic, they are indeed anti-carcinogenic. Now, to make it simple, when you start with estradiol, then you get the so-called catechol estrogens, 2 and 4-hydroxy, and from this you can get the so-called quinones, and the quinones can destroy DNA, and this can, via error in the repairing, lead to mutations, and this can at the end lead to breast cancer. This is very simple. The mechanism is much more complicated. It looks complicated, but I can explain it in a few words. Starting from estradiol, you get the catechol estrogens. From this, you get the quinone, and together with oxygen, radicalic oxygen, there is also so-called semiquinone, and this together is a complex which can be measured directly also in the breast tissue. And this is the potential carcinogenic complex which can destroy DNA and then can lead indeed to breast cancer. But indeed is important that it only works if you have radicalic oxygen. So you need additional factors to get those so-called genotoxic quinones, which can destroy DNA. Now, we can also say that with estradiol metabolites and the key enzymes, we can have a carcinoprotection. As often in the nature, we have the carcinoprotection by the so-called COMT, the COMT. This enzyme can eliminate the catechol estrogens from the system before it gets the quinones. So this is a way of carcinoprotection. Another way of carcinoprotection is that if the quinones are produced, then the so-called quinone reductase can reduce it again to catechol estrogen, and DNA will not be destroyed. So this is a protective mechanism, and the glutathione system can eliminate the quinones before it destroys DNA, also a protective mechanism. So only if all carcinoprotective mechanisms fail, we get the DNA destruction, mutation, and last not least, the breast cancer. Now we can screen for polymorphisms which work in a way that the key enzymes work or do not work. And this is intensive research done for many years to look which genetic polymorphisms can inactivate those key enzymes. And in this context, I go only on the CO-methyl transferase as an example, which is important to make a detoxification before breast cancer is produced. And we have investigated, and other people, different enzymes which can be protective in this way. And there is a biochip technology with microchips where you can measure on one plate about 1,000 different mechanisms which can lead to those polymorphisms, which is important to assess if there could be a detoxification or toxification. And there is also the possibility to screen for the precursors of potential carcinogenic metabolites, screening for so-called 2 and 16 metabolites. which are increased in breast cancer patients. Here you see the radical estrogen is increased in breast cancer patients, another is decreased. So measuring those um, radical estrogens in urine is a method also to look at the metabolites, if they are carcinogenic or not. It's a very simple method of urine, and you can also do it in blood. We have published already years ago that the ratio of those metabolites, 2-hydroxy and 16-hydroxy, may predict the breast cancer risk under certain preconditions. And this ratio is different between oral and transdermal uh, application. Here, one of our studies where we have a control with 300 patients, 156 breast cancer patients, and we see a decreased ratio of this 2 and 60 hydroxy uh, derivatives. Now, the main toxic product are the quinones and the semiquinones, which we can measure in breast cancer tissue, but until now not in blood. So we can only indirectly from breast cancer tissue make any conclusions. But this production of the semiquinones and quinone complexes are different in the amount when you give oral or transdermal HRT. And this is now important. It needs additional factors like pollution, smoke, certain chemicals, or certain diseases to get the carcinogenic semiquinone complexes. So not only the estradiol is important, oral or transdermal, it is only important if you have additional stress, oxidative stress from the cell coming, for example, with pollution. The production of those genotoxic quinone, semiquinone complexes need a so-called one electron oxidation. This is oxidative stress, which is coming from pollution or certain drugs, certain diseases. And only if you have additional oxygen here, then you get semiquinone, quinone complexes. And this can be assessed by spectroscopy in breast cancer tissue. And we have a breast cancer research, especially in towns with bad environment in China, where we can assess that those complexes, semiquinone and quinone, make a complex increased when we have bad environment. Now, this is a complex slide only to show that after the so-called one electron transfer of oxygen radicals, when we get those intermediate products, quinones, semiquinones, we have a cascade which we know from molecular oncology, which is initiated by those radicals. And this is what oncologists are measuring, but we in the biochemistry are looking in the first step how we can initiate by certain radicals these steps which are important in oncology. And this additional excessive oxidative stress induced by smoke or certain diseases is necessary to produce the quinone semiquinones, which I just show you. And this was the result of a conference many years ago with the title New Role for Estrogen in Cancer, published in Science. On the right side, here is the paper of Science, and you can see although estrogen was supposed to act mainly as growth factor in promoting cancers, new work suggests that products it forms in the body may also cause mutations. And these products here, you see the hydroxy estrogen, 4-hydroxy, 16-hydroxy, and the oxygen compounds. Just the same what I have just show you, and it was also known 20 years ago, but not often investigated because it needs biochemical research, and it is also important, only important when you have additional factors. In science, it already was described that you need smoke, environmental factors, and we know also certain drugs can induce the semiquinones. And so this is also an important mechanisms. And so we say that the World Health Organization, which classifies as estrogens as carcinogenic, is only true carcinogenic when you have additional oxygen stress, so additional factors which are necessary that those compounds, those metabolites of estradiol are carcinogenic. And the development of potential carcinogenic estrogen needs those additional factors, the stress, the so-called one electron transfers, that we get carcinogenic metabolites. And this metabolism can be different between oral and transdermal estradiol application. This is for many years known, but it is very difficult to show it in research. And the key is that you need additional factors like oxidant stress to have these problems. And the problems are not only with estradiol, they are even more with equine estrogens, which may produce even more toxic and potential carcinogenic estrogens than the estradiol. This has been published in many papers many years ago, but clinicians do not very often investigate this, with the exception, which I told you, in special institutes where they look at these mechanisms, like Richard Sandon, very famous in USA, who, like in our lab, is investigating the so-called catechol estrogen pathway for the development of breast cancer. Now, the development of potential genotoxic estrogen metabolites, the mechanism is semiquinone-quinone production, needs the stress from polluted areas, or needs certain drugs or certain diseases. And this can be reduced. Now is important, the production of the precursors of potential carcinotoxic metabolites can be reduced when we use transdermal instead of oral estradiol treatment. So we can expect that this mechanism is different between oral and transdermal treatment. And we have also many years ago already shown that to avoid the production of the precursors of the quinone, semiquinone metabolites, we can use transdermal estradiol instead of oral estradiol. Oral estradiol give tenfold higher amounts of those precursors of estradiol. This means estradiol metabolites, which can be further metabolites to quinones and semiquinones, and the semiquinones quinones complexes can destroy DNA, and then by mutation can lead to breast cancer. So the conclusion is transdermal instead of oral estradiol reduces the production of certain strong proliferating E2 metabolites, which are derived from catechol estrogens. Catechol estrogens are the precursors. Transdermal instead of oral estradiol reduces the precursors of the carcinogenic semiquinone-quinone complexes, which, however, are only produced with additional unrestricted oxidative cell stress. And I come back to my second slide, was from Shapiro, that we have only the possibility for the individual women looking if certain mechanisms deliver those additional oxidative stress, which in these mechanisms via metabolites are important to see a difference between oral and transdermal HRT. My acknowledgement goes to China, where we get the funding of this research. I get from Chinese government the highest award in China, and with this money we make this research. We have also from the mayor of Beijing got great support of the research. And the question which I did at the beginning, does transdermal estradiol provide less breast cancer risk compared to oral administration? My answer is yes, but only with certain conditions, delivering excessive, unrestricted oxidative cell stress, like pollution, smoking, certain chemicals, certain drugs, and certain diseases. Thank you for your attention.
Thank you very much, Alfred. I would like to invite also John Stevenson to come back, and we will start a general discussion. We have received a huge series of questions. Please, John, can you?
I can hear you.
Biomedical to add also Professor Stevenson.
I see John and you.
I think you've added me.
Hi, John. Okay, thank you very much, both of you. We have received a huge series of questions, and I would like to start. Okay, we will. I am going there. We will. Okay, then this is from Oranite Goldratt. John, would you recommend starting hormone replacement therapy in a woman in her 40s, still menstruating irregularly, but having some symptoms of menopause?
Yeah. If you've got somebody who's pre or perimenopausal but are getting menopause symptoms, then yes, I think it's absolutely reasonable to be able to give them HRT. Absolutely reasonable. The important thing is, of course, that if you give them cyclical HRT, which is what we would do, then you need to fit that in with their own ovarian cycle. Otherwise, they'll get somewhat erratic bleeding. But yeah, if they've got estrogen deficient symptoms, then it's perfectly reasonable to give them estrogen replacement.
Then, thank you very much. Then, Alfred, we have a question. Two main mechanisms for development of breast cancer based on science and on Human Health Organization.
Again, the question.
Yes. Oh, the question is, okay, there are two main mechanisms for development of breast cancer based on science and the Women Health Organization.
Yes. One is proliferation mechanism, and the other is metabolism of E2 via catechol estrogens to quinones, semiquinones complexes, which can destroy breast cancer, which can destroy DNA and can lead via mutations to breast cancer.
Thank you. And then now, John, from Oranite Goldratt, what about women with thrombophilia, with and without history of embolies?
For any patient with increased risk of VTE, and thrombophilia, of course, is a major risk factor, then it's been shown by French studies that there's no evidence of an increased risk, a further increased risk of VTE if you give the HRT transdermally. So in somebody with a thrombophilia, we would definitely recommend that if they have to have estrogen for any reason, that should be given transdermally, unless it was in an older woman where you could possibly, as our recent research showed, you might be able to get away with a very, very low dose, the ultra low dose of oral estrogen.
Thank you. And then, Alfred, you have mentioned that during transdermal estradiol, are estradiol levels lower compared to oral estradiol. Can this reduce the breast cancer risk?
I think it can reduce the second mechanisms via the metabolites, but the second metabolism needs additional oxidative stress. So the answer is yes, even we do not see it in studies, but we have no direct studies comparing oral and transdermal estradiol head to head. But from the theory, it is very clear that this mechanism via metabolites is reduced when you use transdermal estradiol. So when you have the additional factors like pollution or certain drugs, certain diseases, it should be very clear that we had a reduction of breast cancer risk according to this mechanism of metabolism. But we have no difference in the proliferation mechanisms.
Thank you very much. And then John, Old Belliard from Belgium, she's asking, Are the benefits of hormone replacement therapy on cardiovascular system identical with tibolone and with SEC, then CE plus SERM?
Okay, so with regard to tibolone, then in terms of the cardiovascular system, it's not the same as HRT. The problem with tibolone is that probably because it's fairly androgenic, you do get some adverse metabolic effects from tibolone. And so, no, it wouldn't be the same at all. Tibolone actually makes insulin resistance worse. It reduces HDL cholesterol and it doesn't lower LDL cholesterol. So metabolically, it's not great. It's good for bones and symptoms, but not for the cardiovascular system. With regard to the SERMs, then we really don't have a huge amount of data to answer that one way or the other. But there's no particular reason why one would think that there would be any harm for the SERMs, but not necessarily the same benefits.
Thank you. And then now, Alfred, a question you mentioned, this is from an anonymous, like what certain disease that will induce breast cancer with oral estrogen? What kind of diseases you are speaking about?
Other than breast cancer, or?
Yes. In relation to breast cancer, what kind of diseases you believe they should be considered to have a possible effect on oral estrogens?
The difference between oral and transdermal is the question. Yes, we have a reduction of venous thromboembolism with transdermal, which is very clear. Is this your question? Or we have also a reduction of stroke risk. I think this is more a question to John, but it is very clear that using transdermal estradiol in the cardiovascular field is a huge advantage. In the breast cancer field, is much more difficult because in the first place, the blood levels are important for the breast cancer risk and not the liver, but the liver is important for oral versus transdermal via the catechol estrogens, which I have shown in my talk. So the difference oral and transdermal in the liver, we see in the breast cancer research with a second mechanism, which is not proliferating mechanism, but metabolites. But it is very clear that we have differences, but this is a topic of John. We have a difference between oral and transdermal in the cardiovascular field, also in stroke. And I think this is more a question to John.
Thank you. And then Pilar Virgil for John, please. She asked, do you consider plasma levels of estradiol in the women together with the dose administered? And she tell, we try to keep estradiol plasma level between 50 to 70 picogram per ml. What is your idea on that point?
In terms of the cardiovascular risk, then we don't know that there's a necessary level to be at. We do know from our many bone studies that measuring estradiol levels does not give you any indication of the efficacy, and that, for example, a woman who has an estradiol level of, say, 150 picomoles per liter can be losing bone it can be gaining bone on that estrogen replacement, and yet the next woman that you see who has a level of 300 picomoles per liter can be losing bone. So the inter-individual variation to a set level of estradiol is so huge that it just renders the whole thing completely meaningless. I should have incidentally just should have mentioned in my previous response with regard to the SERMs and cardiovascular risk, there is one big study on raloxifene where they did show an apparent benefit, but that was if the women had started the raloxifene at a fairly early age. So it was a bit similar to what we saw with HRT. So there's a possibility of some benefit in younger women.
Thank you. And Alfred, another question, interesting one, from Afşil Cecil, I think from Turkey. estrogen receptor negative breast cancer is defined newly. Would you begin hormone replacement therapy for menopausal symptoms for this woman?
It is, according to labeling, it is a contraindication, but I think we can use it when we make explanation to the patient that it is a contraindication, but if there is a strong indication for climacteric symptoms, I would use it.
Thank you. And then one question for John, for you. If we have, this is from Ola Semeshko, if we have women with premature menopause, with low testosterone, can we use androgenic progesterone? And will it increase all risk? And should we check? Okay, now this is the first question, and at that point, the possible use of androgenic progestogen in women with premature menopause and low testosterone.
Yeah, the fact that they've got low testosterone wouldn't really influence my decision on this. I'd still prefer not to use androgenic progestogens, even in these young women. But if that was the only way you could give them HRT, then that's better than doing nothing.
Okay, and then one other question from Alfred for you. What are the preconditions for potential lower risk of breast cancer during transdermal compared to oral estradiol?
The question is, what is the precondition?
I'm sorry, we don't hear your voice well.
That we have a difference between oral and transdermal.
Yes, precondition for potential lower risk of breast cancer during transdermal compared to oral.
As I told in my talk, that that an increased breast cancer risk is dependent from two main mechanisms: proliferating mechanisms or metabolism via catechoestrogens. And the second way, via catechoestrogens, there can be a difference between oral and transdermal, which I have showed in my talk. So the second mechanism can be lead to a difference between the risk, but the second mechanism needs additional oxidative stress. So only when you have special conditions like smoke, like pollution, like certain diseases, it has been shown, for example, with LE, lupus erythematodes, that it also can lead to different metabolism, or certain drugs can also lead to those conditions where you have additional oxidative stress. So you need additional cell stress, oxygen cell stress, and then you have a difference between oral and transdermal. And this is what we are just investigating in polluted areas. We have more the mechanism that we have in the polluted areas, more also the second mechanism of development of those carcinogenic metabolites. So the answer in simple word is you need additional oxidative stress to see a difference between oral and transdermal estradiol with respect to the breast cancer risk.
Thank
The
you.
additional oxidative stress can come from very different sources: pollution, drugs, diseases, and this is the answer.
Thank you. Thank you so much. You know, it's very difficult to evaluate the quality of the pollution according to the location where you are living and what happened also during your daily life, and the possibility that stress is strongly influencing the answer. Thank you very much, Alfred. And then we have a question from Alvaro Monterosa from Colombia, and a very pleasant friend. There are studies in terms, this is John for you, there are studies in terms of cardiovascular benefit from the use of estetrol and neurokinin receptor 3 antagonists administered for the management of menopausal symptoms?
Yeah, in terms of estetrol, there's really not sufficient studies to be able to draw any conclusions. And the same is true for the other inhibitors as well. So we don't have any answers for that as yet, but I'm hoping that with future research we'll be getting those answers.
Thank you. And then now from Peter Greenhouse for Professor Mueck. United States clinicians have suggested that there is a better breast cancer risk reduction in hysterectomized women with CE only in WHI than seen in estradiol-only studies because of an hypothetical benefit of one of the 40 CE metabolized. Does he think there is any merit or biologically plausibility of this theory?
Yes, but the question is in the direction if the progestin addition can lead to different metabolism of estradiol, and the answer is yes. So it can really be true that that estrogen-only therapy has another condition regarding the metabolites. But what we know that estrogen only make a slow proliferation, at least 10, 15 years. It was one of my first slides, is needed that you get from the first breast cancer cell by doubling, etc., the 1 centimeter, which you see clinically in the mammography. So estrogen only very slowly proliferates. So the chance is very high that you get a deletion of this developing pre-cancer before it is clinical cancer. When you add synthetic progestins, then the proliferation is very fast. And so after 5, 6 years, you can already have the 1 centimeter in the mammography. So the answer is that especially the stronger and faster proliferation with progestins can lead to a higher risk of breast cancer, earlier seen than with estrogen only. There can also be a more different answer in this question. The progestin addition can also make a variation in the metabolism of estradiol. This we and others have investigated. So if we add certain progestins, this can lead to another metabolic pathway, and this can also lead to another spectrum of breast cancer risk. But there are not many studies on this, but this is an interesting question, how progestin addition can alter the metabolism of estradiol.
Thank you very much. And then now we are approaching to the end. A question for John. How much early we can start hormone replacement therapy to prevent cardiovascular disease, or which will be the criteria selection to start hormone replacement therapy? This is from Cruz Gutierrez de Jesus from Mexico.
Sorry, could you give me the first part of that question again, please, Andrea?
Yes, how much early we can start the hormone replacement therapy to prevent, for prevention, cardiovascular disease, or which will be the criteria selection to start hormone replacement therapy?
Yeah, so in terms of how early can you start it? Well, I mean, that doesn't really matter. In terms of the criteria, one has to bear in mind that at the present time, prevention of cardiovascular disease, and particularly coronary disease, is not a licensed indication for the use of HRT. So you have to bear that in mind. If you're selecting patients that you might want to give HRT to, then obviously one would look for women who've got obviously increased cardiovascular risk for whatever reason. But then to be able to give them HRT, you'd have to have a licensed indication as well. So really it would be if they had any menopausal symptoms at all, then that would be a fair reason to say, yes, let's start you on HRT, and then you could expect the cardiovascular benefit as well. So it doesn't matter how early you start it, you've just got to find an indication.
Thank you. And then we have a question of Elena Rota and some other questions that I put together. This is for Alfred. Concerning the impact of progesterone and progestogen. What is the lower impact for breast cancer in these families, and how we have because we heard that androgenic progestogen, they have a major cardiovascular risk in comparison to progesterone or dydrogesterone. But your comment about the breast.
No, it is very clear that the natural progesterone and isomer dydrogesterone have less breast cancer risk in some studies, clinical studies, and we see it also in the experimental field. When we investigate proliferating mechanisms, then we have a difference between progesterone and dydrogesterone and the synthetic progestin. So according to proliferating mechanisms, it is very clear that the use of natural progesterone or its isomer dydrogesterone can reduce the breast cancer risk. Now, regarding the second mechanism via metabolites, we have no data if there is a difference when we add progesterone or the dihydrogesterone regarding the metabolism. So the impact of different progestogens on the metabolism of estradiol is not well investigated. But we have investigated with norethisterone, which increases the production of catechoestrogens, and we have it also with progesterone. So we see, and it is published, we see a difference, but it is more research needed to see if progestins, which impact have progestins on this second mechanism via metabolites. Always going in this structure that we have two main mechanisms. We have the proliferating mechanisms and we have the metabolites which can induce breast cancer risk. And for metabolites, we have not much data concerning progestogen addition.
Thank you very much. And then now the final question, one for John and one for you. For John, I take the question from Typhoon Badges because I think it's quite stimulating. Do you believe that all women should start hormone therapy as soon as menopausal transition for cardiovascular health? Why the guideline refuse this approach?
I certainly don't think that all women should go on to HRT at the menopause, because not all women are going to develop cardiovascular disease anyhow. They're not all going to develop osteoporosis. They're not all going to develop dementia. And if they haven't got any menopausal symptoms, then they don't need HRT. It's as simple as that. There's going to be no advantage to giving it. Whether there are detriments can still be argued. But certainly I wouldn't say all women should go on HRT at all. No, definitely not.
Thank you. And then now last question for Alfred. This touch specific type of women. I take the question from Avci Cecile, and I bring my regards to also other friends such Teffi Kyoldemir, which are hearing our webinar. Okay, Avci Cecile asks, woman who has an history of familial breast cancer before 40s, and she has got the genetic mutation clarified, such as breast cancer, BRCA. Do you give HRT?
According to the WHI data, there was no difference between Mueck mutations and non-mutations with the risk. So according clinical study, you can do it. And according the two main mechanisms, proliferation or metabolism, I can say that I have no problem to give it in this women, because this is not the mechanism which is important to change proliferating mechanisms or to change the mechanism via metabolites. This is another mechanism which is important, but not for the difference between oral and transdermal.
Thank you. And then I don't resist. John, we have another question that I don't resist not to do, because I would like to hear your answer. I have mine, but I would like to hear you. And then she's from Hannah Yozan. When we need to stop hormonal therapy? Never.
Now,
Yeah, so When should a woman stop her hormone replacement therapy? Unless there's any major contraindications and she's getting benefit from it, I would say the only time she needs to stop it is when she dies.
Thank you very much. Okay, and then the final message, Alfred, a final message
can I
concerning your topic.
I would say a critical time is 5 years, because after 5 years, we have seen in the experimental field and also in clinical field that there can be a development of breast cancer starting from the first breast cancer cell. So I would say after 5 years, I am more critical to continue with HRT, but I would agree with John that there is no reason to stop it forever. If we decide after 5 years together with the women that there is an indication to continue, for example, if she has osteoporosis or if she may develop hot flashes after stopping, so I would continue year by year. But in my view, after 5 years is a critical time to decide if we continue, and this way I make it year by year, a decision individually with respect to the risk factors of the women in front of me.
And then, then I have to make a question to John. John, what I have to do with my wife? She is doing yet since more than 40 years the hormone replacement therapy. I know because you're bringing her to these tablets.
It certainly doesn't seem to have done her much harm, does it, Andrea? And she's fit and well and flourishing with her hormones. Who would dare try and stop it for her? I wouldn't let them.
Okay. Dear friend, dear John, dear Alfred, thank you. We had a fantastic webinar. We have touched the most important arguments. You have also mentioned osteoporosis, and I would like also to mention mood and behavior and what are the effects on the brain. That hormone replacement therapy done with intelligence is a fantastic help for the women. I thank both of you for your fantastic lecture. Thank you, John. Thank you, Alfred. Enjoy your life. And I would like now to go to the topic of the next webinar will be on metabolic syndrome in women. And we will have two masters, our treasurer of the our president of ISGE, Professor Tommaso Simoncini, and our member of the board, Professor Andrei Milevich. They will be the 4th of December at 3 o'clock. They will discuss metabolic syndrome in women. And then, dear friends, I would like also to remind you that next ISGE Congress will be the 22nd World Congress for us 40th anniversary of the ISGE will be done not in Florida, but will be done in Rome, March 4 to 7, 2026. Enjoy that one. We wait you at our next webinar, and I wish to all of you, to your families, all the best. And I thank again my dear friend John and Alfred. We have a very pleasant afternoon together. Thank you very much and have a good day.
Thank you. Bye.
Bye, dear friends. Bye. Thank you.
Thanks, Andrea.
Bye.
Thanks, Alfred.